So welcome to the latest of the ECIST Emergency Care Improvement Support Team webinars. Today we've got my colleague Richard Brownhill, who's a Senior Improvement Manager with ECIST, and he's going to talk about emergency department nurse staffing, considerations and deployment. So over to you, Richard.
Thanks, Pete. Morning, everyone. I just thought I'd talk to you today about emergency department nurse staffing, something that I guess I've got a few years experience of, but in the last couple of years I've been fortunate enough to spend quite a lot of time out and about in different emergency departments, talking to staff and seeing some of the challenges that go on there. And what I wanted to do is to bring some of those together and share some learning from some of those observations. So this webinar is really to look at a few things. So to look at ED nurse staffing and their workload, to stimulate some thinking about how and where staff sort of work, the way in which people work. And as I said, really, to share some thoughts around improvement. I think one of the interesting things about staffing is it has changed in lots of places, sometimes for the better, I'm sure. It doesn't stop the fact that people are working in an incredibly challenging environment, and it's compounded by many of the factors that we're aware of through ECIST work, which is around patient flow. So what I don't want to do is necessarily rehearse any of that conversation, but absolutely accept that it's an integral part of the challenges of frontline ED staff every day. But it's important to acknowledge that. So I kind of split this into a number of different parts, thinking about when we're looking at staffing, we want to think about the patient care demand. So the different departments that exist, some will be major trauma centres, some will be urgent care centres. So we're probably talking a little wider than just the ED. We may be talking a little bit more about the urgent and emergency care environment when you're considering staffing. Some of it's about the tasks. So I guess in my 20-odd years of career, there's been a humongous change in tasks that nurses were originally doing or originally weren't doing, and have now transitioned into care support workers performing. So thinking about some of the tasks, it's important that we think about the right model of care delivery and being able to offer that with the most competent pair of hands. The environment, so already alluded to the fact that demand in the emergency department has increased, so that there are a number of departments that are struggling in terms of the size of their physical footprint and the volume of patients coming into the department. So again, that compounds or can be part of the problem as much as it can be part of the solution. Roles that people play. So advanced practice now being a really common feature in most departments, and how that's changed the course of what we do, and indeed the course of direct caregiving, core care to patients, is not necessarily always done by nurses now. And I'd stretch that out to say we're increasingly seeing roles of extended scope physiotherapists, OTs, working in frontline frailty services within the ED, to support that whole team and that patient care. The processes, so we may be doing things the same as we've always done them, which means we get the results that we actually get at the end. So are there opportunities to think about the processes? And of course, most importantly, we need a buoyant group of energetic staff to continue the work within the ED. This will look pretty standard to most people. So this is a pretty typical ED occupancy pattern. And the reason I'm kind of starting with this is to show a couple of things. For me, staffing, the key with nurse staffing is to look at occupancy. So looking at attendances may not be as immediately relevant, but the volume of patients in the department and the care that they need from the staff are a really important area to make sure that we align. And you can see that overnight, whilst the occupancy might be perceived to be lower, there's still a critical or core mass of staff we need to fulfill the service. And sometimes people working outside the ED don't really understand that. They often will look at attendances and say, well, if people are not coming in, you probably don't need that many staff. Yes, the lived experience is we often still have quite busy departments at that time of the day now. So taking staffing as a kind of numerical concept and looking at attendances, if we looked at average attendances, we may not fully reflect the workload that staff are experiencing. And what we know from workforce planning is that if you pick up just the average, you'll get it wrong half the time. You may get it right half the time, but the challenge there for staff is that you will be at either end of that extreme. And I'm sure most days it doesn't feel like you're at either end of the extreme. You're probably operating in the 80th percentile. So first things first, I'd say it'd be really important to get some data. So what's your attendance pattern look like? And can you ask your business intelligence people to calculate that at the 80th percentile for you? So you get a sense of the volume and the occupancy and the group of people that are in there at a particular time of day. I think the other thing about the department and its occupancy is thinking about the subsets of things that go on within the department. For instance, streaming. Excuse me. So streaming, for instance, it will matter the attendance numbers of the patients. If you very simply get 10 patients an hour and streaming takes you 2 minutes per patient, you need 20 minutes of staff time per hour to be able to operate that. And that's notwithstanding that not all patients will tell their story within 2 minutes. So, but it is important to get a proxy measure to be able to calculate some of these things. That will help you both to understand and probably as importantly to articulate to other people what the work is and indeed why the demand is such. So taking data really and having a look at hourly staffing, this is registered nurse staffing, but hourly staffing across a department, you can see on the upper diagram here, the ED1 has got a rota that matches pretty well with demand. And all that's happened here is I've taken the occupancy of the department and the hourly registered nurse presence, if you like, and matched those two together. So that department already has a pretty good match. My experience in going around a number of departments is many departments are somewhere near ED1. So the expertise, the quality and the ability of senior leadership teams in EDs is already out there. And I think it's really important that that's acknowledged, that people already know what they need. And some of the challenges are sometimes being able to articulate or explain that to others. So with the help of things like this, that can do that. And I'm happy to help anybody that wants some assistance with that. You can see the second ED is a little bit more challenging. So the demand is high into the early hours of the morning, if you look at the left-hand side. And then as the evening goes on, or the early hours of the morning go on, the demand falls and the staffing starts to rise. So this is a department where the rota's fairly flat. So they may just have a 1 or 2 shift pattern across the day. So quite typical of long days, lots of people in a day shift, lots of people on a night shift, maybe a little differential, but not much in the middle. So this department, about 2 o'clock, if you look on the graph, you can see that the demand is going to outstrip the rota and continue to be a challenge right up until about 3 a.m. So here's a department that typically I would talk to and triangulate that with and say, what does it feel like in the afternoon? And staff will typically say, well, we're trying to do lunches, we're trying to sort out the patients that are in there, we're just starting to get some beds that come in batches, and as we try to move patients, it's getting harder and harder and harder. So what is really important to me is the data is only the data, and as ever, the data is an opportunity to have a conversation. And so the conversation is, this is what it looks like in the data. Is there an opportunity to think about what we might do differently? And typically, I'd recommend that department tries perhaps to put a shift in there from midday till midnight and see if that helps, and run that as a test of change. I mentioned streaming. So this is just to say, this is streaming demand. So again, if you look at your attendances per hour, and then the minutes you've got available for a 2-minute process, you can see this department, who runs streaming from 8 AM till 10 PM, will broadly speaking be able to manage that demand. You can probably also see that whatever service or system they put into place after 10 o'clock at night might mean that patients may be waiting a little bit longer for whatever it is in terms of their first assessment. So it's just, again, a way of being able to numerically work out whether you appear to be aligning your resource appropriately to your demand. So this is kind of a bit of a summary, just to say that we should aim to match overall occupancy with our resource, and most of it is predictable. So while staff will often say, oh, ED, you know, it's wonderful, it's not predictable, I guess from hour to hour on a given day it may not be, but when you take the broader approach, it is. And that may include weekends, surprisingly. The case mix may be different. So I think there are parts of the country, certainly, where if you're a seaside resort, your case mix may be very different, for instance, at the weekend. It's important to consider your core functions in your department and use testing numbers, as I mentioned, about things like streaming, and map your staff time accordingly. I think key for me is being able to share the data with staff. This is not an exact science. It's probably an art and a science. So some of this is around how staff feel, how productive they are, what we can do as leaders within organisations to help people function more effectively. And I think showing people some of the numerical graphs respects the fact that people feel under pressure sometimes, and is the reason why things are not working as well. It's not because they're not working really hard. It's because actually fundamentally there's a mismatch between the capacity and demand. And I think that's really important to play that back to people. And I think it's really important to kind of spin the positive around myth busting. So there are examples. Ashford St Peters have got a really good example of a kind of lithograph wall chart where they show the number of staff who've come into post this last month on their staffing board. So being able to say to staff, it might feel like the same work and it's challenging, but actually we've 3 more staff than we had last month, etc., etc. So it's really important, I think, to communicate some of that stuff back. And some of the learning from those type of things you'll see on the NHS retention website if you want to go there, which is part of an initiative to recruit and retain staff within nursing. Just moving on a little bit, think about your layout. So again, how your department is laid out. This is a really nice linear department. Relatively easy probably from the nursing station to see your teams. Some of the modern departments we've got, some of which are incredible to look at. I will mention Croydon if nobody's been there. What a really nice department. But like many new departments, there are multiple subsections. So staffing that area is not the same as it would have been for a department that has a layout as simple as the one you can see on the screen there. And then think about some of the processes that we undertake. So I was in a department recently where they operate streaming, or they call it streaming, which is really triage, which there's another part of the process that is then triage, and then the patient goes on and maybe get some bloods or an ECG or something like this. Those kind of core functions at the top there are pretty standard in most departments now, but I'd urge people to think about, are they value added? Now, clinically, they may add some value, which is slightly different, but sometimes we're having streaming processes that are really triage, so they're taking 2 to 3 minutes, maybe even 3 to 4 minutes. Triage, which is now not triage, but some form of secondary assessment, where you've been sent into the ED process and you're having a bit of a workup and a conversation. So I think it's important just again to be aware of streaming's not the panacea for everything. What it should be doing is directing some of the patients to same-day emergency care areas and to urgent care areas, and trying to reduce some of the demand on the ED in a safe way. It's also there really to make sure that patients are assessed in a timely manner. And I think that's really, really critical given the volume and the demand of walk-in patients that we have. I mentioned core functions, and I'm not going to read through the list. You'll be familiar with all of these different things in your department, but it is important to resource them and resource them appropriately. Again, considering the demand. So if you've got 30 ambulances an hour arriving, you need a different model to people who've got 4 ambulances an hour arriving. And trying to, in a model where you've got 30 ambulances arriving, get somebody to multitask. So one department I visited had the nurse in charge also doing ambulance handover, and they were trying to manage the department and do ambulance handover, and we were looking at somewhere in the region of 15 ambulances an hour arriving. Well, that is almost an impossible task for that individual. So I urge people to think about the core function, but also to consider some of that timing again. Resus, I think it's probably a given. I know ratios are not something that people widely talk about within nurse staffing in ED, but it is important to acknowledge that if you're in a high dependency unit, you would be talking about a staffing ratio of 1 to 2. So I think resus is probably a fairly given area as to where you'd want to exercise that sort of standard. And obviously if you're a major trauma centre or have some other high dependency tertiary needs, for instance, you may well wish to consider that within your staffing model. Majors, sometimes it's easier to think about zoning into teams or allocating into cubicles. And I think the big feature here for me is the amount of patients that come in by ambulance that often will need to be admitted who are in majors are people that probably have high dependency and not necessarily high acuity. So these are people who need pressure area care, pain relief, fluids. They need to sometimes have nutrition, medication, and some of these functions can be easily supported through healthcare support workers. Notice I'm not saying, transferred to healthcare support workers. I think it's really important that we have a blend. But I think there's a real role for healthcare support workers, particularly in the majors area. And lots of departments have adopted that. There's a number of other departments that may not have done and will really struggle if, for instance, the qualified nurse thing goes on transfer to leave their zone or that area effectively unstaffed or substituted to someone else. So continuity is important there. Ambulatory majors, more and more people are walking into departments, but that doesn't mean their acuity is low, but it is an area that is not historically as prioritised as trolley majors areas. But an area we're seeing a lot is where this is resourced really well, then you can reduce potentially crowding in your own department through improving the processes in the ambulatory majors area. Considering that 25% of people may be admitted, the other 75% may be within your gift to try and improve some of your occupancy within the department. And I guess urgent care and PEDS models vary dramatically, so that presents another bit of a challenge around how we staff and how. This is just a nice example. I think this is from Huddersfield Royal Infirmary in Yorkshire, and they've developed an ambulance handover area that used to be a plaster room, nice 5-spaced ambulance assessment area, self-contained, and just strikes me as something that staff have taken on and really made their own in terms of ambulance handover. Ambulatory majors I mentioned, this is from the North Middlesex Hospital, where lots and lots of improvement work's been done around a fit zone and sit to treat area. This is around trying to push the volume of ambulatory majors into an area where the mentality of both staff and patients are around trying to create fit to sit, trying to deal with your care in a chair, as they would describe it, and really trying to make the most of optimising both their staffing resource and their patients being in an area where they're more likely to be rapidly sorted out and discharged and on their journey. So just some other things to kind of think about, really. Acuity and dependency in the physical footprint in which you're working, so I've alluded to that a little bit. Consider that in the mix. What are the core functions and allocations you need in the department? And substitution and breaks. So one of the things that staff may do is have a working model where it's not clear or built in that staff will need breaks. That may sound really simplistic or a criticism, and it's not, but it is really important that we build in the sustainability for staff to actually have breaks. Incredibly important that we are not surprised by the fact that staff will need to have some rest time, and therefore the continuity of care and the substitution of those staff is really, really key. Think about interdependence with other staff groups. So I've mentioned people like frailty staff, maybe EMPs. There are some departments where EMPs will perform a triage function or will relieve in areas of the department. If that's an appropriate model for you, absolutely fine. Nobody's saying there's one right model. And of course, you've got all that nursing expertise. I guess the balancing metric, for want of a better term, is if your challenge is around seeing patients and seeing power, you might want to consider whether that's the best use of a specialist nurse's time. So, but some of that can fall down to who you've got in the department and who you've got available. There are some departments that have carved out specific roles, and I'm thinking in particular of resource-specific roles. So you may have some people only working in the resource room and other staff outside within the ED don't. That may be an appropriate model for some departments, again, without saying one size fits all. I think it is really, really key to make sure that we are making the best of our rounded skills within emergency care. So considering how we continue to build the capability of our staff around the department without perhaps losing the ability to have specialist skills in certain places. It's worthwhile thinking about who's best placed to deliver care and why. So there's often some major differences between healthcare support workers, for instance, who only provide simple clinical care, maybe do dressings, others who will be doing arterial blood gases and suturing once wounds have been assessed. I think the range is huge, but it is worth thinking about, are we in a position where we're making the best of what we've got? And I'm not advocating that we're substituting qualified nurses. I am saying the absolute expertise of qualified nurses is there to provide that holistic approach, that management of the patient's care, very much in ED, the specialist skills of the ED nurse, providing medication, etc., etc. Just to say, I'm not sure what your uplift figure is around your staffing, but the National Quality Board in their UEC report in 2018 talked about this should be around 25% for EDs, and the reason for that being that the amount of specialist training, so CBRN training, triage training, etc., means that you will need an appropriate uplift within your team to allow you to conduct the activities that you do. Thinking about productivity, and productivity, I guess, is an interesting term and maybe sounds like we're judging people by how much we think they should be doing, what their output is. I guess I'm taking a broader view on productivity, just saying, how do we get the best out of the staff we've got? So let's just be really simplistic about that. Often we have increasingly diluted the volume of staff in the ED in terms of their skill mix. So what we were hearing 20 years ago about newly qualified staff coming into ED as their first job, there are more now than there have ever been. Some of that is about the supply. That's no bad thing. And there are many departments where the infrastructure and the induction program is so brilliant that actually those staff are no worse off than they may have been 20 years ago. So I think throwing the baby out with the bathwater and saying we're suddenly in a very different place and qualified nurses shouldn't be coming to the ED is probably a little bit outdated, both in terms of what we now experience and some of the way in which teams have responded to that through the great induction programs they've got. But it is important to have a competency framework, and the RCN have produced a really robust competency framework. If you've not seen it, it's worth going to look at and implementing in your department. Certainly having a look at to try and work out where the skills gaps may be and how you can rapidly improve some of that for your teams. There are departments where there's transfer teams, so that makes life easier to transfer patients to the ward, particularly when you get a chunk of beds being delivered in an afternoon, which is the experience in many departments. mental health staff, so there are mental health teams and suites within some departments. And again, that helps in terms of substitution. And it's worthwhile thinking about what would help. So looking at your environment, are there some standard processes that would make things better? Are there some improvements and opportunities around, calling patients into cubicles may improve, for instance, productivity of medical staff. And whilst it might seem like a really simple thing and may be something that you disagree with, it does improve productivity because the patient's delivered more quickly to those people. So thinking about your environment, thinking about some of those processes, and I guess a little bit thinking about lean standardization there. Test some theory, so give something a go. Most people that are practicing in the ED already know what they think they need. Give something a test, but do measure it. So do decide what you want to achieve, do measure it, and do talk about the learning and do share that learning. And I think that's the challenge sometimes around the discipline of doing that. So you may have trialed something, but actually nobody really has fundamentally measured what actually was the outcome. And I think it's really important to be keen on sense checking that staff are okay. So human factors, fatigue, having time out. And a couple of departments I've visited recently have got time out spaces for staff. So you can just go and have a couple of minutes when you've had, a difficult conversation or you've transferred a patient with some real challenges, just to go and spend 2 minutes gathering your thoughts and being ready for the next sort of patient. The National Nursing Research Unit, and the reference there to 2015, was a piece of work commissioned about long days, in particular 12-hour shifts. And I would just suggest that it may not be, certainly from some of the evidence there was poor decision making and sometimes poor continuity as a result of those shifts. I just urge people to consider their shift times and fatigue, particularly in a busy ED for 12 hours. And that can have an effect on other people. And anybody that's heard of this term civility may be familiar with some of the work that's been done around that and the increasing focus on how that affects the team and how that affects the productivity of the team. And I just wanted to mention sort of human factors, slightly tongue-in-cheek. So people can feel like they're superheroes sometimes, and that's kind of good. It's really not that good. You need to eat, drink, rest. You need to have some thinking time. And the little photograph on the right-hand side you can see there, there's no escape. So in this particular department, there's even learning opportunities on the toilet. So that's a kind of mixed message that says I really like the innovation of that, because people do read things on toilet doors or walls, but actually there's no escape even there sometimes. So it might be as equally as helpful to put an amusing picture that just gives you a bit of a chuckle. And I mentioned Chris Turner's work on civility, and just to really say that measurably, people being nice to people is so key. And I know it's easy to be in a bubble in ED and to work together as a team and to think everybody outside can feel like the enemy sometimes. That may be a reflection of some of this civility. And all I'd say is it's really important that we all, across the board, try and help each other to be strong and resilient, but also to recognise our effect on other people. You might be asking yourself, thanks for all this is stuff we know, etc., etc. But so what? In the lived experience of ED, it's really busy. We need to be pushing, doing our work every day, looking after those patients. I think if you just pause for a few minutes and thought, what can I do? Well, what can others do to help you too? Get some data. Spend a few minutes looking at what you do and where and how, and are there some things that you could improve? You will already have some great ideas here. How you crystallise those ideas and make them into an improvement is really, really important too. But it might just be a simple test of change. So that might be that coffee room conversation that then becomes, why don't we just try that tomorrow? But perhaps talk to other people so they know you're trying it. That gives you a better chance of being able to operate. And help others outside the ED gain insight into what you do. So some of this is, I know it's really difficult. I know it's incredibly challenging and frustrating when people aren't listening to you. But I guess some of the insights I'm trying to share with you in my ED work over the years has been trying to convince others about what the world looks like within the ED. And I think there's a skill in itself there, and hopefully some of what we've talked through today will help with that. And if not, absolutely more than happy for you to get in touch and have a conversation.
Thanks for that. I'm just going to, if it's okay with you, just going to ask a couple of questions.
Yeah, sure.
Because you covered an awful lot of ground there. If I was a member of an ED nursing team or a medical team, or you know, I wanted to convince others this is the right thing to do. I don't know. Maybe I've proved numerically that we've got a gap on, you know, between 2 p.m. and 10 p.m. at night. And I want to test out, you know, putting an extra staff nurse in or something like that, something similar. How would I go about doing it? And I'm not used to this. I'm clinical. I'm not managerial. I haven't had that experience. And I maybe perceive I work in a culture where it's pretty difficult to get this type of stuff, this type of change. What would your advice be there?
So I think the starting point is sharing that data with somebody, and also not using the word pilot.
Yeah.
I think one of the challenges often is we talk about a pilot, so we might try a pilot for that period. One day, one simple test of change. So is it feasible? Can we put somebody on between that time and run a test of change? Would anybody be prepared to do that? It might be a staff meeting conversation once a conversation with the senior leadership team has taken place. That just says, you know, is anybody up for trying that? But part of the engagement process around showing staff why we're doing something is really, really key. So sharing that data with everybody and saying, what do we want to do about this? Do we want to give it a test? And I think within that then, as I mentioned before, being really clear about what you're measuring. So if that person was going to give you more streaming power, is it about the time to initial assessment? If that person's going to give you better cover on the floor, is it about time to medication, for instance? So you might do a sample of medication on that shift and do a baseline before that. One department actually did that and improved their medication giving time by 20 minutes. So again, it is possible to think about that. And then I think test it and talk about it. And this is not a one-stop shop in the sense that you try it and then it stops. I think part of that improvement journey is just giving something a go and then sitting down and saying, what did we learn? And you may have learned that actually on that particular day, it didn't make enough of a difference. You might need 2 people between that period. And so part of the healthy discussion is the so what. What do we do next then? What has that taught us? Albeit that staff may say, well, you know what, we may not have seen any improvement in certain metrics, but it felt better. And for me right now, that's really, really key. That's really important that staff feel better.
Okay, and then one of the figures you mentioned in your presentation was the 25% uplift figure quoted by the National Quality Board. So I know that this is maybe a slightly controversial question, but maybe I'm working in a trust and there's a huge cost improvement program targets, and they say we can't afford 25%, Richard. You know, we can afford 20%. Imagine I'm the senior nurse for ED. How do I go about persuading people that actually this is exactly the right thing to do? The 25% covers annual leave, general time off, maternity leave, or study leave, all those type of things. How would I persuade people this is the right thing to do? It's also the most efficient thing to do as well.
So it is contentious. We don't have a limitless pot of money, and I appreciate there's always a balance in there somewhere. There's something here about the narrative. So even if you couldn't have 25% because the financial purse strings stop you having that, I think there's a story that goes with it about articulating that we require it. It's in the NQB guidance, but also here's our measurable amount of study time we need in this particular department. So it links really well with practice education, which I've not talked much about, but any department that doesn't have dedicated practice educator time, again, that will be a massive challenge and will be a compromise. So taking perhaps practice educator and or the team and looking at what the development needs are is a really important part of that process. and being able to map that into a time period and recognising what that time is will be part of the discussion around where that 25% sits. So I think it's important, whatever the number, that there's sufficient time for people to gain those skills and to be in a position where they're equipped to do the job they need to do, and that indeed the senior nurse in the ED isn't having a cyclical weekly conversation about why they've got a cost pressure and they've sent people on some training. So I think some of it's pragmatic. It's around sharing that number, so it's a recognised number, but it's also about trying to find a solution, but recognising or helping others to recognise the impact of not resourcing that particular thing on staff development, and therefore arguably the skill mix and the quality of the service that you're providing. But it's about having a dialogue, and I think many of these things are. That's not going to be the only contentious number that we've got, but it is important that we get on the same page to try and explain to people the view of the world and why that will have an impact on our teams.
Brilliant. Okay, well, thank you very much, Richard. So let's call the webinar to an end. If you want to contact Richard, his email address is on the screen, along with his Twitter handle and the ECIST Teams network Twitter handle as well. And thank you very much, Richard, and hopefully we'll run another webinar, maybe building on this one in the near future.